Thank you. And good afternoon, everyone. Yes, I want to present an analysis of the socioeconomic determinants of diet quality and health among the EU elderly. And that's the result of a collaboration within New Age among Luke, my own institute in Finland, the University of Bologna, the University of Reading, and in Sweden, Karolinska Institute. And yes, and as Aurelia said, I'll present a little bit about the New Age data. So obviously all the recruitment centers have contributed to the data collection. So first of all, just a few words about the rationale and the structure of the socioeconomic work package. So why a socioeconomic work package? The idea is fairly simple. If we want to promote healthy aging through healthy eating, we need two things. We need a good understanding of what a healthy aging diet might be, and that's the point of most of the New Age project. But we also need to understand behaviors and why elderly people adopt different types of diets, so that if we understand it, we might be able to change it, and the elderly might adopt healthier diets. And that's what this work package is about. The initial work package was organized in two tasks. So the first one is an analysis of the behavioral determinants of diet quality. That's what I'm going to present. And there is a second task that is more specific about foods with nutrition and health claims and how to communicate to the elderly. And Sophie Hieke from UFIC will present that after me. So for this first task, we've got a number of subtasks, 4 of them. 3 were in the original research plan, so we started with a brief literature review. Then we have a statistical analysis of the correlates of diet quality in 4 EU countries. Then we tried to develop a fuller behavioral model of dietary choice, a model that was applied to the UK and Italy. And these 3 first tasks were based on secondary data and published literature, so independent of the intervention. But then at the first kickoff meeting of the project, it was decided that it would be a good idea to introduce a socioeconomic component to the intervention. So there's a bit, a small socioeconomic module that was added to the general questionnaire. And I'll say a few words about that, but very briefly, because we haven't even had time among partners to discuss this. So first of all, of course, there's been quite a bit of previous work on the diets and the food choices of the elderly, both in public health, but also in psychology, in economics, in consumer science. So we try to review these. That literature was very useful in identifying some potential drivers of healthy versus unhealthy diets. The factors that are mentioned most frequently are listed here. So quite a bit of emphasis on resource availability and income and affordability of food, the economic constraints. The health status, obviously the functional ability of the person is going to influence his or her ability to not only eat, but also to cook or shop. Household structure and social networks are emphasized, access to healthy food, education, and knowledge. So lots of factors, but rather few general results, in particular in an EU context. The second point is that there's quite a bit, it's quite clear that the nutritional problems and the population is quite heterogeneous. There might be a need to distinguish the young old from the old, and maybe these different categories might have different preferences for food and diet. And the third conclusion from this literature review was also that there's not been so many attempts at applying behavioral theory to the elderly. So there's a lot of fairly descriptive studies but few examples of, I don't know, the applications of the theory of planned behavior or economic theory to the elderly. So we started our investigation, as I mentioned, by looking at the correlates of healthy versus non-healthy diets. So in order to do that, we needed data, so we carried out a data mapping exercise, secondary data, so I'm not talking about the New Age data now. We selected 4 data sets for the UK, Finland, Italy, and Sweden, quite heterogeneous. Some are individual level, some are household level data, different levels of or degree of detail in the description of the diets. So that's an important caveat. But we have observation about 15,000 observations, so a reasonably large data set. And the approach was fairly simple. We tried to regress an index of diet quality on potential drivers of choice and adoption of these diets. So the diet quality index that we chose is called the DQI. It's described here. At the time, we had a few interactions with a nutritionist. Well, something to mention is that we concluded this analysis more than 3 years ago. So the deliverable was due in month 18. So at the time, the New Age index unfortunately did not exist. So we had to use something else, and we chose this DQI, and we can discuss it if there are questions. And then we regressed it on a common set of variables, independently for each country, and to try to keep from the temptation of mining the data too much, we defined a common structure for all 4 countries, ex ante among the partners, and then we ran it. So some of the results, first of all, the level of diet quality in these 4 countries is rather low on average. So there is definitely much room for improvement. And also the distribution of these scores is quite spread. So there is, and in particular, our score scale, it was a score very much like the New Age score, going from 0 to 80. One can observe that this is just for Sweden, but very few people achieve sort of top marks. So there is something to learn about why some people are here and some people are here, and that's what we are trying to do. And these variables that we threw into these regressions had some significant explanatory power, but it's not huge either. In these cross sections, we get R squared between 10 and 20%. So I'm not going to present the result in great detail, but there are 3 groups of results. So each column corresponds to a country, and each row corresponds to a different potential driver of diet quality. And the result is summarized by a sign to express the direction of the relationship. So if we take the first row, we find that people living alone tend to adopt diets that have a lower quality than people who live in couples or with family. Okay. What's quite nice here is that we ran these regressions separately for each country, and we find fairly similar patterns across the 4 different countries. So living alone, that's strong, except in Sweden, where it's not significant. What shows up strongly in the results is the educational variable. More educated people adopt healthier diets. Gender, females, again, adopt better diets. So we know that males and females are different from a biological point of view. That's what Claudio was saying this morning. But also from a behavioral point of view, it looks like they are also different. And there are some quite strong regional effects. Then some results were a bit less expected. So what came out was this variable about resource availability, so income if you want. So this was measured quantitatively for the UK and Finland, and we found the opposite of what we thought we would find. So people who are relatively better off tend to adopt diets that are of lower quality. And in Italy, it wasn't clear. The relationship was nonlinear, and in Sweden, it was not significant. And also, when we control for income and we look at how much money people spend on food, we call that preference for food, we find also this negative relationship. So if you want foodies who want to spend quite a bit of their budget on food, tend to adopt diets of lower quality. And finally, for some other determinants, the results were less regular across countries, but with respect to socio-professional category, I mean, we had for some of the data, we are going down to age 50, and what came out of this is that retirement didn't seem to be a major factor. So when people retire, the quality of their diet doesn't seem to change radically, and also age was not that significant. So some partial conclusions. First of all, so poor diets among the EU elderly, it doesn't seem to be primarily an economic problem, so it's not a problem of cash poverty, if you want, but more what some economic historians have called a challenge of affluence. So this describes the difficulty of making rational choices when the number of options is increasing and the temptation might be increasing, and people might have difficulty making the right choices, quote unquote. In a way, that's good because it means that there is room for targeted public health interventions to try to improve the situation. Education, as I said, is positively associated with diet quality, but there is also a message in terms of targeting, so target males living alone with low education. And also, we thought that the results were showing that preferences for food were pretty constant in old age. And all the details have been published in 2013. Then we extended the model to try, first of all, to look at health, because the relationship of diet quality and health is interesting because the causality might run both ways. We know that diet quality affects health, but equally obvious is that health might affect diet quality. For instance, people who are obese might change their diet in order to lower their weight, or diabetic people change their diets to control their disease. And so it's a bit tricky, and we had to develop a model because we have this feedback loop. So we built a model based on economic theory, a model of lifestyle choices and health. I won't list all the assumptions, but the key assumption is, of course, that people can affect their health by choosing healthier lifestyles. That's the key assumption. And the structure of the model is presented here. We've got a number of constraints in green. So people have a certain age, a certain environment, a certain number of socioeconomic characteristics, a certain income. Also, their past decisions and their genetics is summarized by a so-called health stock. So what diseases have they already contracted? So diabetes, for instance, high blood pressure. And given those, they make choices about diet quality, but also other lifestyles, such as smoking or physical activity. They make choices that have no impact on health. Diet quality and these other lifestyles, together with the health stock, determine their self-assessed health, how healthy they feel. And in turn, all this contributes to well-being of these individuals. So that's very schematically presented. So we estimated this model for the UK and Italy, and the latest version is only for Italy because we've got a very rich data set. We've got 25,000 individuals. And it's essentially, I mean, the main result that comes out of this is that diet quality affects health even in old age. So that's kind of good news. And what's important is that it's self-assessed health. So what it means is that, and also that it's conditional on health stock. So what it means is that even if people have some chronic conditions, they have high blood pressure, diabetes, or that sort of things, and they adopt healthier diets, what we find, if we believe the model at least, is that they are going to feel healthier in themselves. It's not just in an objective sense, okay? And about this direction of causality, we found also that objective health influences lifestyle choices, and the direction is that when people are getting less healthy, they choose to invest more in their diets. There is a sort of compensatory behavior that we find in the data. There are a number of other results that I won't discuss, and all the details are in a couple of conference papers that are available on internet. Finally, the New Age data. So as I said, we introduced a socioeconomic questionnaire. So the good thing is, of course, that we've got lots of information about health and food already. We've got repeated observation, T0, T1, and even at M4 and M8 sometimes. And then we introduced things about basic sociodemographic characteristics. But now we also had some questions about barriers to healthy eating, questions about attitudes, knowledge, importance of health as a food choice motive, and other things suggested by the behavioral theories in psychology mainly. And we also introduced some variables based on the economic theory of behavior. So time preferences, how much you value the future versus today, risk preferences as well, the tendency to engage in risky behavior. We try to measure these things in the questionnaire, in the survey. And I'll just present two regression results. So this model is, so first of all, I'm just dealing with T0 data, so I'm saying nothing about the result or the effect of the intervention. So that's just cross-sectional. And at T0, and we regress an index of diet quality on some basic sociodemographic that was similar to what I presented and summarized in that public health nutrition article. And the nice thing is that it's really consistent with what we found. So gender effect, being male impacts very negatively on diet quality. Income, as assessed, as measured by self-assessed financial situation, doesn't show as being significant. Education shows very strongly. So all these green effects are consistent with what we obtain when analyzing secondary data, and the age effect is the same. What doesn't show is the living alone, well, the significant effect of the living alone variable. Then, of course, the advantage of the New Age data is that we have some measures of these psychological constraints or constructs and other things. So we added some different variables here. So, for instance, one could think that major life events such as becoming a widow or getting divorced might have a large impact on one's diet. We don't find that this is very significant. The one thing that comes up as very significant is health knowledge. And we feel that this is very consistent also with the very large coefficients that come on the educational variable. We extended the model by looking at different BMI categories, and then some other things are becoming significant. For instance, this notion of time preferences. So people who care more for the future tend to adopt healthier diets. So these are very, very preliminary results for the New Age data. As concluding remarks, I would insist on the robustness of the findings using different types of data. And what shows up is, as I said, these economic constraints don't seem to be so important in driving adoption of poor diets. But what's very important seems to be education and knowledge. And certainly there are some implications for public health measures. So the traditional public health tools of informational campaign, nutritional education might actually work. And that links very nicely to the next presentation, which is about nutritional labeling and knowledge and claims and that sort of things. And of course, we've just started looking at the data set. We need to do a lot more. And in particular, I think what's very interesting is going to look at the determinants, not of the level of diet quality, but the change in diet quality in the intervention group. And you know, is it the more educated? Is it people who start from lower levels in particular? And all of these things. And also, we are building different scores about the strength of social networks to capture other dimensions. So thank you very much.